All right, let me welcome you back to our symposium today and to our second panel. This panel is going to focus on the politics or the political challenges going forward with respect to healthcare reform. We have a very distinguished panel. It will begin today with Paul Pierson. He's to my immediate right here. Paul is the John Gross Professor of Political Science at the University of California at Berkeley. Professor Pierson attended graduate school at Yale University, where he earned a master's in arts and philosophy and a PhD in political science. Prior to teaching at UC Berkeley, Professor Pierson taught at Harvard University, and he has written extensively on American politics, political economy, and public policy, including healthcare policy. He will be followed by Chris Faricy. Chris is an assistant professor of political science here at Washington State University. Dr. Faricy earned his MA from the University of Michigan and his PhD from the University of North Carolina. His research focuses on American political institutions, political economy, and social policy. Our third panelist today was going to be Senator Karen Keiser, who serves as chair of the Washington State Senate Committee on Health and Long-Term Care. Unfortunately, Senator Keiser was informed last night that the Senate was going to be in session today, and for some reason she thinks it's more important to solve the budget issues in the state than to be here with us. But she sends her regrets and would have liked to have been here. We were very fortunate, however, to be able to convince Dr. Glenn Stream to step in at the last minute. Dr. Stream has been a family physician serving the Pacific Northwest for more than 25 years. He currently serves as president of the American Academy of Family Physicians, and in that role, he advocates for changes to healthcare policy on behalf of family physicians and patients across the country. The AAFP represents more than 100,000 physicians and medical students in the United States. Dr. Stream received both his BA and his MD from the University of Washington, but I told him we won't hold that against him. Our final panelist today is Professor Jay Kennedy. Jay is an associate professor in health policy and administration at WSU on the River Point campus here. Dr. Kennedy received his PhD from the University of California at Berkeley and his MA from the Claremont Graduate School. Dr. Kennedy is on the editorial board of the Open Health Services and Policy Journal, and his research focuses on disability and aging services, as well as health, rehabilitation, and long-term care policy. And I will turn over the time now to Professor Kennedy, who will serve as the moderator for the panel as well.
Well, thanks for sticking around. I think I'll emulate Patricia's moderating of the first session, so we'll give 10 to 15 minutes for each speaker, and we'll hold questions until the end, and then I'll kind of wrap up and moderate the questions. So go ahead.
Okay, I think I'm just going to sit here since I don't have any PowerPoints for this. And I want to thank the organizers and the Foley Institute for having me up here. When I got the invitation, I wondered if they had gotten me confused with my frequent co-author, Jacob Hacker, who really is a healthcare expert. I'm really not. But I'm a political scientist who's followed vigorous fights over domestic policy in recent decades, and I think my role here is really to kind of confess that I'm not that knowledgeable about the intricacies of this very intricate policy area, but maybe say something about the broader political context that can help inform the conversation. And I also want to say at the beginning, at least until the Q&A, I'm going to skip the Supreme Court. We'll find out in due time. There are many possible scenarios, but having been on a panel the other day at Berkeley on the Obama presidency that quickly degenerated into a bunch of non-lawyers attempting to discuss constitutional law with none of us really knowing what we were talking about, I think it's better for us to focus on some elements of the politics that are clearer, or at least where we have some sense of where things stand in a way that we really can't with respect to the Supreme Court. Wilbur Cohen, maybe the founding father of Medicare and Medicaid, really, at the time that those bills were coming into shape, described advancing policy as 1% inspiration and 99% implementation. Just from the panel earlier today, I think we got a sense of how complex some of the implementation issues are in the case of the Affordable Care Act. And what I want to do in the time that I have is just to mention what I see as three distinct political obstacles to the implementation of this act that people are going to be wrestling with over the next few years, assuming that some part of it survives the deliberations of the Supreme Court. The first obstacle is, and maybe the most obvious one at the moment, is the heightened partisanship that characterizes contemporary American politics, what political scientists refer to these days as polarization. And just a biographical word here. I grew up in the Northwest. I grew up in Oregon. Last time I was in Spokane, I think, was for a high school debate camp at Gonzaga. Town's grown a little bit since then. But growing up in Oregon, I actually feel like my own biography fits in some ways with the transformation of American politics. I grew up in Oregon, which was really, at that time, a state where bipartisanship reigned, and where the Republican Party in particular was marked by a reformist and moderate orientation. I think of senators like Wayne Morris, who later became an independent but started as a Republican, Bob Packwood, Mark Hatfield, many other less well-known political figures, but prominent within the state, who were Republicans, but often reached across the aisle and had, I would say, much more openness towards the idea that government had an active role to play in addressing public problems than is true of the Republican Party today. So I grew up in Oregon. I now live in California. As a native Northwesterner, I still can't quite get used to the idea that it's a California driver's license that I'm carrying around, but I'm slowly adjusting to it. Those of you who know Sacramento, or a little bit about what's going on in Sacramento these days, I think in many ways it shows the path that the nation is on. Washington, D.C. looks increasingly like Sacramento, and I have to say that's not good news. Because what I mean by that is that it's a political system that is characterized by parties that look increasingly parliamentary. Right? They look increasingly like separate blocs that vote in lockstep fashion. And there are many very successful parliamentary systems around the world, but most of those systems, maybe all of those systems, do not have a feature that California has and that Washington has, which is substantial supermajority requirements for passing legislation. So in California, that's a result of Proposition 13. In Washington, it's primarily a result of the filibuster in contemporary politics. My own view, maybe we'll get into this a little bit later, more is that you can have parliamentary politics or you can have supermajority rules. It's very difficult to have both. Right? It's very difficult to have parties that are really organized as completely competing teams and then say that either of them can block legislation. Right? But that's the world that we've moved towards. So spent a lot of time talking about polarization, but let me just mention a couple of the most important features of it that apply to thinking about the implementation of healthcare. There's more and more distance, ideological policy distance between the two parties in today's politics. I think the evidence is pretty clear that this is primarily because the Republican Party has shifted to the right, rather than, as it's sometimes characterized, that both parties have pulled away from the middle. We could argue about that. But one way to just quickly capture how big the gap is, if you take the Democratic position on healthcare policy today, which is really embodied in the Affordable Care Act, and contrast it with the vision that is embodied in the Ryan Plan, right? And fast forward to the year 2020, if those different policy blueprints are implemented, the difference in the number of people likely to be covered to have health insurance between those two visions is probably 40 to 50 million people. That's a big difference. So there's a big distance between the parties on many issues. There is, with the increasing polarization and shift towards a sort of parliamentary style of politics, there's a change in incentives facing actors within the parties. Politics becomes more zero-sum, right? If it's a gain for the other team, it is almost by definition in this world a loss for your team. Right? It is much harder to reach compromises in that kind of context. In the old system, where the two parties were much looser coalitions, different actors within those parties had different incentives, and you could often reach across party lines to reach a compromise. But in a situation where it's the red team versus the blue team, that's much more difficult. And finally, all of this is happening within a context where the American political system has really increased the capacity of the minority to obstruct the majority. And here I'm referring to the dramatic expansion of the use of the filibuster in recent years. It's important to recognize it's often talked about as if the filibuster is a constitutional feature of American politics. It's not. The filibuster was used more often in the first 3 years of the Obama presidency than it was in the 1950s, 60s, and 70s combined. Medicare and Medicaid would probably never have passed if people used the filibuster the way that they do today. If they say all legislation requires 60 votes in order to pass. So partisanship, we now see potentially another source of minority influence or control over the policymaking process, which is the Supreme Court, right? Which I would say in the recent arguments sets itself up almost as like a third branch, a third chamber of the legislature in evaluating healthcare reform. So once again, that's a possible point where electorally the minority party is in a position to block legislation from the majority that passed the healthcare reform legislation. So one whole area of difficulty for implementation has to do with the increasing partisan polarization and confrontation in American politics. The second has to do with the role of concentrated interests. And this is sort of staple of political science, that concentrated interests tend to have an advantage over diffuse interests, that because they have a bigger stake and it's easier for them to organize, right? So dairy producers care more about the price of milk than dairy consumers do. Right? So even though there are fewer of them, they tend to be more organized, more focused, and they can place a heavier thumb on the scale of public policy. Right? This is a staple of the study of politics and policy making, but if one thinks about implementation issues having to do with healthcare, it's a very prominent part of the politics that's likely to take place going forward. Concentrated interests have an advantage over diffuse interests. That means producer interests have an advantage over consumer interests. That's one of the reasons why we're now approaching 20% of GDP going towards healthcare, why the remarks of the first question on the first panel, why do we spend so much more money than any other affluent democracy does, with, I think, pretty dubious evidence that we're getting good value for that money, and a lot of it has to do with the role of concentrated interests in American politics. Even if you think about the origins of the Affordable Care Act, when the Obama administration got going on this issue, the very first thing they did, before they even started talking with people in Congress, was to get most of the most powerful producer interests to come into the White House, and they tried to bargain agreements with them. Right? With the AMA, with the pharmaceutical industry, with the insurers. Some of those agreements stuck, some of them didn't, but it's telling that even before they went about the business of trying to put together a coalition in Congress, they tried to make deals with producer interests because I think they rightly believed that if they were not pretty successful in that effort, they had no chance of getting 60 votes in the Senate. So concentrated interests are important in all parts of American politics, but they're especially important when you get to the murky, slow-moving, low-visibility, complex world of policy implementation, right? Which is the world that we're now moving into with respect to the Affordable Care Act. There are many, many struggles, policy struggles, to be worked out over the next few years, and my expectation going into that would be that the organized groups, which are mostly on the provider side, are going to be likely to be quite effective in lobbying to make sure that their concerns are being met. So that's going to be an important part of the politics. Then the last one that I just want to mention, oh, and I should add, that tends to be even more true at the state level than it is at the national level, right? Given that state level politics tends to be less organized, producer groups tend to have an even stronger advantage in trying to affect implementation at the state level than they do at the national level. The third obstacle to implementation, I wish I had more time, but I'll just say this, try to say this pretty quickly, is that there is a broad context of financial austerity, right? Big battles over what we're going to fund in government. That is clear, that is the backdrop to a whole range of policy issues going on, but obviously that's going to be very relevant to healthcare and thinking about how the healthcare plan is going to be implemented, if it's going to be implemented at all. There is a lot of redistribution built into the Affordable Care Act. There are a lot of subsidies built into the Affordable Care Act. But this is happening against a backdrop where there is going to be enormous pressure to cut outlays from government rather than to expand them. And again, just like political scientists tend to think that concentrated interests have an advantage over diffuse interests, they would say that if politicians are trying to figure out where to save money, they're much more likely to go after subsidies that are promised to some people in the future than they are to take away subsidies that already exist for people in the present, right? Those folks are much more likely to mobilize against cuts than people who aren't going to get subsidies that they've been promised, but that they don't even know exist at this point. And that's doubly going to be the case in a situation where their subsidies are going to people who frankly have very little political power, right? Low-income, working-class Americans. Right. So in a context of austerity, those subsidies, I think, are under an enormous jeopardy. One can see that one place that one can see that is by looking at the Ryan plan that the Republican caucus just voted as House budgetary policy. Projected out by 2020, they're talking about a 30% cut in Medicaid expenditures from what would exist under current law, and that's not even including the subsidies for Medicaid expansion that are built into the Affordable Care Act. That's on top of eliminating those subsidies. Right? So this context of broad austerity is a very important part of thinking about the politics of implementation going forward. All right, so that's all from somebody who, I'll confess, like me, thinks that the Affordable Care Act, for all its flaws, was an important step in the right direction. Anybody who needs a reminder of that, take a look. There's a powerful op-ed in the New York Times today, actually written by a former colleague of mine, Andrea Campbell, describing what happened to her sister-in-law, who did not have health insurance and was in a terrible automobile accident. And it's if you want to see a story about the failure of current healthcare policy in the United States, read that essay. So, sounds glum. Try to end on a slightly, because these obstacles to implementation of the reform are truly massive, and it's not just one obstacle; it's multiple obstacles. But if you went back to the early 1930s when Social Security was enacted, right, you could see a story there where, in its early days, Social Security, which I consider one of the truly great pieces of social legislation in American history, maybe the greatest piece of social legislation in American history, it didn't start out as a full-blown program that provided basic income security to all Americans over 65. Right? It started out as a much shakier program. And in the earliest years after it was adopted in 1935, it was extremely vulnerable, strongly opposed by national Republicans and by many organized groups. And really, in most people's telling of the history of Social Security, it's not really until the 1950 amendments, right, 15 years later, that Social Security begins to become institutionalized in something like the form that it exists today, and its political future seems to be relatively secure. So inevitably in American politics, social reforms face a tough road, right? And it takes a long time often to figure out what's going to happen to them. Senator Tom Harkin, one of the supporters of the Affordable Care Act, described it as a starter home. It's not complete. But given how hard it is to do major legislation in the United States, it represents a really important achievement. And so the challenge, just as it was in those early days of Social Security, but I think it's fair to say in an even more difficult and political environment today, the challenge is to see what happens to that starter home during the inevitable political confrontations that are going to happen over the next few years.
All right, good afternoon. My name is Chris Faricy, and I'm here to speak about the partisan politics of the divided healthcare system. What I intend to do is simply to present a theoretical argument for how to understand the politics that surrounded the passage of Obamacare and healthcare reform going into the future. Now, first, let me begin by saying that there is no one theoretical argument that could possibly encapsulate fully the complexity of healthcare policy, and that's not what this is intended to do. But what I do offer it as is a competitor to the existing narrative of the politics of healthcare. That existing narrative stems from Medicare and its passage, and I'll argue is at best incomplete, at worst it no longer applies and is false. And that existing narrative is that when the Democratic Party is in control, that they increase social spending on health care. And when Republicans are in control, they decrease spending on health care. Now, that traditional narrative doesn't take into account two extraordinarily important facets of both health care and politics. The first is that our healthcare system is divided. There's two. There's a public healthcare system, and there's a private healthcare system. And that, again, that theory doesn't take into account that there are two. And more importantly, for the politics of healthcare, the federal government is involved with both. So my theoretical argument takes into account both the divided healthcare system and the role that the government plays in both of them, especially when it comes to financing. And I make what I think is a simple and hopefully an argument that resonates, that the Democratic Party prefers the public provision of health care, and that the Republican Party favors the private provision of health care. And it's these preferences over which sector of the economy finances and administers the system which is critical to understanding the politics of healthcare reform in the United States. Let me start by going back to the partisan debate over the public option. So if you remember that in the period before Obamacare was passed, the Democrats floated this idea of a public option which would allow people under the age of 65 to buy into a Medicare-type program and compete with private health insurance. Okay? This created a big partisan stir, and I'd say that Paul's co-author is often credited as being the father of the public option, Jacob Hacker. So here's a quote from a letter that 14 Republican senators sent to President Obama on 7/5/09. And it says, Washington-run programs undermine market-based competition through their ability to impose price controls and shift costs to other purchasers. Forcing free market plans to compete with these government-run programs would create an unlevel playing field and inevitably doom true competition. So embedded with this is a preference for private-run healthcare and pointing out that the biggest threat to the healthcare system are government-run programs. And again, the implementation that healthcare is a good that should be regulated by supply and demand and some government intervention on the private market. This next quote is from then Democratic House Speaker Nancy Pelosi in a speech she gave to the NAACP about a month after. And what she argues is that we need health care for all Americans, which is a right, not a privilege. And it will have a public option that is necessary to remove the health insurance companies from coming between patients and their doctors. So notice that in this quote that a partial solution to the problems of healthcare reform is the public option, a government-run program, and it's needed to stem the threat of health insurance companies, private companies interfering between their patients and the doctors. Also notice that the treatment of healthcare isn't of a good or commodity, but is a right of citizenship. So I think these two quotes encapsulate nicely the critical differences between Republicans and Democrats when it comes to the view of healthcare. Before I get into presenting the theory, I want to unpack some of the important concepts into understanding this theory. First, I've talked about the divided health system. So let me explain what I mean by this. The public system is represented by Medicare, a federally run program targeted towards the elderly, and also Medicaid, a joint federal-state program that assists the poor in receiving health care insurance and benefits. On the private side, I'm mainly referring to employment-based health care insurance and benefits. And as Paul mentioned, it's important to note the uniqueness of the U.S. healthcare system. Okay? The OECD is an international organization, and the latest round they did on private social spending and public social spending, when it broke out healthcare, the United States in 2007 spent 5.6% of the gross domestic product on private healthcare. That was 5 times amount the next largest country in what they spent. So if you would look at European countries, the United States spent more on private health care than the next 4 countries in line. And you combine that with the 7.2% of our gross domestic product spent on public health care, and the aggregate means that the United States, as well known, spends more on health care than any other Western industrialized country in the world. And I think that what is not understood is that our ratio and our mixture of healthcare systems, so not only is the size of our healthcare system unique in international comparison, but so is that ratio of public to private healthcare. Now, the government role is that it's well known that direct spending goes towards Medicare and Medicaid programs. In 2010, $743 billion was spent on that, or 79% of total healthcare spending. But what is not known as much, that according to budget experts, economists, and policy analysts, they also include, in doing budgetary analysis, all the targeted tax breaks in the system that go towards subsidizing employment-based healthcare. And this is an accepted policy tool. It has been counted in the United States. They've calculated the amount of revenue lost to the government since 1967. It's used in 43 state budgets and by every industrialized Western country in the world. So what we know is targeted tax breaks, and the one that's most common here is the tax deduction that we receive for employment-based health care, which, by the way, currently is the largest social tax expenditure program in the code. That in 1970, it was the 8th most expensive program. Now it's the 1st. So it gives you an idea about how healthcare costs is causing an increase in government spending, not only through Medicare and Medicaid, but also through this tax deduction for employment-based healthcare. And the federal government in 2010 spent $200 billion subsidizing employment-based and private-based healthcare. So, one thing to know from this is that what the government actually contributes to healthcare increases on average around 20% over the last 40 years once we include these targeted tax breaks. And the argument for why budget analysis and economists and policy experts consider targeted tax breaks a form of spending, is that if your unit of analysis is the government, then whether the government allocates resources by saying these people can pay the government less to the tune of $100 billion because we're giving them a subsidy for employment-based health care, or the government says we're going to create a public option and spend $100 billion on that, either way, the government's out $100 billion. So when you're analyzing the debt and deficit and the unit of analysis of the government, it doesn't matter whether it's a tax break or a direct spending program. The end result is that the deficit takes a hit. Okay? And the important point here is that direct spending goes to public programs, and for the most part, although not exclusively, tax expenditures go towards private programs. And as I mentioned, my argument is that the parties have preferences where Democrats, when in office, will choose to raise direct spending for public programs while they hold steady or decrease tax expenditures for private ones, and Republicans will do the reverse. Well, they will increase tax expenditures or tax subsidies for private programs and hold steady or limit public spending. And my theory follows from 4 points. First, what's the incentive for both parties, and Republicans in particular, to address health care? Public surveys across 40 years have demonstrated that there is tremendous support for a federal role in health care and tremendous support for increased federal spending in health care, again, across 40 years, to the point of, I have a slide that I won't get to, but if you'd like to see it in the Q&A, there's a popular survey known as the GSS. In 2008, 94% of respondents thought the government was spending too little on health care. Okay? Now, here's the interesting part. Recent research has demonstrated that a majority of conservatives, a majority of self-identified Republicans, and a majority of people who believe that the government should play a smaller role in the economy, a majority of those three groups support a federal role in health care and increased federal spending. Okay, so where I take that to lead is that it's not a viable political option for the Republican Party, like the traditional narrative claims, to abdicate the playing field when it comes to social policy or to simply cut programs. That given the public pressure based upon macro opinion over 40 years, they have to come up with some type of strategy. So that leads me to my second point, that political parties, when they are in power, will design healthcare policy with the following two political goals in mind. They take into account their members' needs and their wants. The members' needs is to get reelected. What the members want is to have their ideology and values reflected in policy outcomes. And they design healthcare policy with those two goals in mind. So what does that mean for healthcare spending? What it means is that they will choose to trade off and substitute direct spending for public programs with tax expenditures for private programs to accomplish two things. One, as a way to target their loyal supporters with both financial and social benefits, and secondly, as a way to shift the balance of power between public and private in society, and a way change the ideological direction of policy outcomes. So these two goals can be accomplished by the, again, selection and trade-off of different policy instruments and spending when it comes to healthcare. So the result is that I would expect Democrats to increase direct spending for public programs that go to their constituencies and represent their values, while Republicans would increase tax expenditures for private spending that would go to their constituencies and represent their ideological beliefs. And now I'm going to turn to some brief evidence for those points. Okay. First, these data are from the Keiser Family Foundation, and they give you a depiction of who receives public versus private health care. Okay. And I've highlighted, this is by employment, by income level. FPL stands for the federal poverty level. This is the amount over, and by race. So you can see here that non-workers, people who are closest to the poverty level, and racial and ethnic minorities represent the main constituencies of Medicaid. Okay? Now, something important to note. This is true for Medicare as well. The working class disproportionately benefits from Medicare versus wealthier folks over 65. That they rely on it more for health care coverage. And if you look at some of the supplementary and disability benefits that are included in the Medicare program, it tilts the balance towards racial and ethnic minorities and working class folks. So both, although Medicare is targeted towards the elderly, if you disaggregate the data of who benefits and who receives these, a lot of more vulnerable populations benefit disproportionately from Medicare. If you look at the employment-based numbers, folks who are full-time, folks who are well above the poverty level, and white workers disproportionately benefit from employment-based systems. And if you look at data from the Keiser Family Foundation or the Employee Benefit Research Institute, what you find is that the average beneficiary of employment-based health care is a wealthy white male professional in a large corporation. Right? So you think about the characteristics of the people who receive public welfare, right? Those are the characteristics you would use to describe who are the base, the electoral base of the Democratic Party. You listen to what I just described as the average recipient of employment-based health care, that is the Republican base. So my argument is that by shifting spending between the public and private systems, not only does it represent the values and ideologies of the members, but it's a way to, as Paul put in the zero-sum game, reward their constituencies at the same time they hurt the opposing party's constituencies. Now, is there evidence that these motivations actually motivate party behavior? And in short, yes. So this is from a book manuscript that I have. And this looks at tax expenditures for private health, private social welfare from 1970 to 2010. And it looks at the annual average increase in tax subsidies for mainly private social welfare. And what you see, the red bars institute Republican control of, here we have the presidency, the House, and the Senate, and that with each democratically elected unit, Republicans spend more in tax subsidies than do Democrats. And you can see that when it comes to the House and Senate, substantially more. Republicans, on average, when they controlled the House, spent double the amount that Democrats did. When you look at the Senate, Republican control of the Senate led to a 7-fold increase in tax subsidies than when Democrats controlled. So the fact of the matter is that there is a Republican welfare state. It's just run through the tax code. Now, I think what's interesting is that I mentioned the potential fallacy of the traditional narrative of party politics and social spending, especially when it comes to health care. Here's some more evidence of that narrative possibly being restricted. So what this does, it puts together direct spending and tax expenditures into one measurement of the total amount of federal resources that are allocated towards social programs and breaks down which party spends more, both by control of the presidency, the House, and the Senate, and then on the right-hand side, I have by presidential administration. Okay? And the simple takeaway here is that the red bars, which represent Republican control, are slightly higher than the blue bars. Now, I can tell you that I've run t-test and ANOVA, and what these show is that although the Republicans are slightly ahead in these graphs, what I'm able to say is that if you take the statement that Democratic Party control leads to social spending, that is not conclusively supported by any statistical tests I've run over the past 40 years. That it's really inconclusive about what we can say as far as party control in total changes in spending. And by these simple averages, Republicans allocate a little bit more, but again, it goes towards different populations. So I'll just end by saying that this theoretical argument, I think, buys us a little more explanatory leverage than what traditionally we think of when it comes to the partisan politics of healthcare. And that when there is change to political party control of government in DC, what changes isn't the total amount of spending on healthcare, but who receives financial assistance from the federal government for healthcare, and the balance of public and private power in society. I don't think this is a parting gift.
Well, I'm Glenn Stream. I'm a family physician and president of the American Academy of Family Physicians. So I'll warn you in advance, I have a very strong bias about primary care and family medicine and how it's important for our healthcare system. So don't be surprised. So what I'd like to talk about a little bit is just, we've framed the politics a lot. I'd like to sort of expand the discussion a little bit, because I think we really focus on the congressional and presidential tension that's involved in this, but it's a lot bigger debate than that. Obviously, there's state government aspects of that. We see that in this state. We have a democratically controlled House, Senate, and governor, and our Republican Attorney General joined the lawsuit in the Supreme Court. And a lot, as we heard in the earlier panel, of the implementation of this law is really focused on state-based implementation, the exchanges being state-based, and those sorts of things. So there's a lot there. Obviously, the Supreme Court will be waiting after their deliberations. Obviously, a topic in the public mind. I'd like to share my pain a little as a leader of a professional organization. We have a little over 100,000 members. In our last member survey, 19% of our members want us to advocate for the full repeal of the Affordable Care Act. And 18% want us to pursue a single-payer health plan. So if you want to make that membership happy, please tell me what thoughts you have, and I can use that help. I think it's worthwhile laying the background a little bit. I like this quote from the President of the United States. Millions of our citizens do not now have the full measure of opportunity to achieve and enjoy good health. Millions do not have protection or security against the economic effects of sickness. The time has arrived for action to help them attain that opportunity and that protection. Can anyone tell me what president said that?
Harry Truman?
Harry Truman, 1945, speaking to Congress. This is not a new issue for our country. Very smart. Gold star day for you. From my standpoint as a primary care organization leader, I think it's very heartwarming what a light the value of primary care was shined on in the process of this political debate across the public and private sector, across the green and the red team that the blue and the red team that we've heard about. A lot of people learned what they didn't know before, which is if you're going to reform a healthcare system and make it higher quality and more cost effective, that really having robust primary care is really what you have to do. And then the tension in reforming our system is we need to expand it to cover people who are uncovered or undercovered, but at the same time we need to constrain cost, because the cost escalation is really bankrupting not just federal but state and local governments and private business, and is the #1 cause of personal bankruptcy in our country, which is just really indefensible. So I believe that improving the primary care system is one of the main answers to how we solve this, is that we expand our primary care workforce, we have better prevention and wellness, we have better chronic disease management, we avoid late-stage illness and the cost that's involved, but also the disease burden it brings on our country, and that we need to move in that direction. So this is the other quote I like. This is from President Obama, an unscripted comment at a town hall meeting in Raleigh, North Carolina, when he was asked about primary care. And it says, it used to be most of us had a family doctor. You'd consult that family doctor. They knew you and your history. They knew your family. They knew your children. They helped deliver babies. The issue of primary care physicians is absolutely critical and has the promise of making such a big difference in the health of everyone, from children to seniors. They are the hub around which a patient-centered medical system exists, and the first step is getting more primary care doctors. And there were some particular features in the Affordable Care Act addressed at all of these issues in primary care, and I'd like to use them sort of as the opportunity to show the background, but also the ongoing political aspects of this legislation. So previous speakers have talked about a number of these. I'm not going to talk about them at all at this point, but the individual mandate, obviously the biggest focus for the Supreme Court. Can they make you eat broccoli or can't they? And then any number of other things, and I'm going to talk about these individually. But I'd like to pause because we were we were talking about the politics behind the law, and I think that a couple of interesting points. And one is that in our federal legislative process, usually the House passes a bill, the Senate passes a bill, they consider each other's bill, they don't like each other's bill, it goes to a conference committee process, they work out their differences, and that process informs a lot of the regulatory rule writing that then goes into implementation. That didn't happen in this bill, and it's led to a lot of the chaos in implementation. So there's a bonus payment, and a bonus is a good thing. The guy's smiling. In the Affordable Care Act, there's a 10% bonus for primary care services in the Medicare program. It's funded for 5 years and is intended to bolster our primary care system. Obviously, my concern is that this needs to be made more permanent, and that 10% really is not enough to undo historical underpayment for primary care services. There's a provision that has to do with making Medicaid payment, at least for preventive and wellness and primary care services, equal to Medicare payment. Anyone who follows health policy knows that Medicaid is the worst payer in any market anywhere, and if you could, at least for primary care services, improve payment, you could then expand access to better primary care services to a broader number of people, and then they would benefit from that primary care as far as their health, but also in avoiding unnecessary expense down the road. It's only funded for 2 years, doesn't take effect until January of 2013. Regulations are languishing in the Office of Management and Budget right now while they do God knows what with them. One of the really interesting things in the law was the creation of the Center for Medicare and Medicaid Innovation, and the idea was to give them literally it's like seed money in a large corporation where you say, here's some money, do something innovative, see if you can find a new way to do something unique and different. And they gave $10 billion to this CMMI group to test new delivery and payment models, and it's where a lot of the ACO and patient-centered medical home sort of models are coming from. I'm going to promote family physicians in my presentation. This is Richard Gilfillan. He was CEO previously at the Keiser Health System in Pennsylvania, a very progressive, forward-thinking, innovative, large medical group, and now leads this group. So they are the entity responsible for the ACO, the pioneer ACO type of things, the patient-centered medical home model. Patient-centered medical home is not a building. It's not a nursing home. It's a delivery model that involves team-based, integrated care. It's not visit-based care. I'm not just your doctor when you come to see me. I'm responsible for you over time, and if you don't come in for follow-up of your diabetes or your preventive wellness screening, I reach out to you and say, you really should come in for this, it's important. And that's a real difference in our healthcare delivery system. A particular model is the Comprehensive Primary Care Initiative out of CMMI, and the idea then is in test markets, supposedly to be announced later this month, they will bring both the federal government, Medicaid and Medicare payers, plus local private payers to the table with a payment model that aligns with funding this patient-centered medical home model. And hopefully this is really going to be that tipping point that gets us moving forward, because once the CMS actuaries can show that this either maintains the same cost but improves quality or does save costs, then this plan can be more widely implemented without further action from Congress. Coverage changes, earlier panel talked a little bit about. I think one of the most important is that, at least for non-grandfathered plans, any new plans issued have to have first dollar coverage for preventive services. This is very important. You know, that $20 copay is not going to prevent women from having their mammogram. And literally in my practice, I see people avoid basic health care screening because their out-of-pocket costs is the barrier. So this is very important. So there are some coverage changes. Again, these were talked about a little bit with the earlier panel. The reason that I put them up there is I think this is a huge problem for the Republicans if the Affordable Care Act is struck down by the court, because there are enormously popular provisions in the ACA. If you ask the public or members of Congress about these provisions and you somehow can get them to block out that it's part of Obamacare, then you know the idea that people aren't subject to pre-existing clauses, or that we can keep our young adult children on our health insurance while they're in early out-of-college jobs and don't have health insurance. These are popular provisions, and if the law is struck down, it's unclear in a presidential election year Congress how quickly could these provisions be addressed to be preserved. And the question that I have too is all these other provisions and a few more that we'll talk about, how do you undo 2 years of work? This legislation passed 2 years ago last month and is well down the road in its implementation. The medical loss ratio, I'm sorry, the insurance guy left in this. Oh, there's right there. God forbid that the insurance company should actually spend money on health care. So
Want to respond to that right now?
The medical loss ratio is that for the premiums that are paid in, the law provides that a certain amount of it, I believe it's 80%, has to be paid out to actually provide health care. And the other 20% goes to the administrative overhead of running insurance. But I think that this is what the money's for. We pay it in, it should be for health care. The health exchanges, I was hoping Mary Schlecke was going to talk a little bit about this, and I know that Karen Keiser would have. The enabling legislation was passed only recently in Washington, but at least we have, as a state, passed our health insurance exchange enabling legislation. Many states haven't. This also is a real political landmine in individual states because your choice is either create your own exchange or have the federal government come in and provide exchange services in your state. And if you are a Republican governor, that's sort of, it's, which light socket do you want to stick your finger in? Because you don't really, you're looking for the third choice. If the individual mandate stands, that would take effect in January of 2012. The penalties are quite small. How much this would incent people to actually buy insurance if the impact, as has been described in the exchanges, is that the cost still is prohibitive for individuals, this remains to be determined. I would share the thoughts of others that the provisions to restrain cost, this escalating cost in our healthcare system were not adequate in the Affordable Care Act. But one of the measures is the creation of an institute called PCORI, the Patient-Centered Outcomes Research Institute. And this is the group that does what's often called comparative effectiveness research. If you compare treatment option A with treatment option B, which works better, both from a safety and effectiveness standpoint. The way that this could constrain cost is if there's currently commonly used treatments that turn out to not be effective, or where the complication rate is greater than the benefit rate, we would save money by not continuing those treatments. Family physician, you might have guessed. This is Al Berg, who's a professor at the University of Washington, one of the smarter people I've ever met, and he's on the methodology committee for PCORI. And they just 2 months ago had their first sort of national launch and are working on how to lay out the scope of their work, which is fairly daunting, and how effective they can be when they're really charged with evaluating the entire scope of medical practice is, again, one of those to be determined. But this is one of the areas where the law often is accused of involving rationing. And the charge to PCORI is they literally are not allowed to consider cost in their deliberations about risk and benefits of comparative effectiveness, and they are specifically not allowed to make recommendations that are thought to be rational. Another interesting piece is the IPAB, the Independent Payment Advisory Board. This was a subject of legislation in effect just last week. The political game goes on. This group would evaluate Medicare expenditures and suggest adjustments, cuts to payment, particularly to physicians, if certain expenditure targets were exceeded. Last week there was a bill in the House that bundled that with liability reform, because if you're going to vote out the IPAB, it's actually scored by the Congressional Budget Office as saving money. So if you want to get rid of it, that actually costs something. So they put this bill in about how medical liability reform would actually offset those, and it passed in the House, and it's not even going to be considered in the Senate because it's just dead in Senate politics in a democratically controlled Senate. So this is the game that continues as we speak. The other thing that I think is really interesting about the IPAB is it's 15 full-time federal employees that are people with understanding about healthcare delivery system, financing, insurance, that have no conflicts of interest. They're going to have to clone these people from embryonic cells. I don't know where you find people that don't, through their historical practice lifetime, have something that would be considered a conflict of interest, especially if you're going to go through a Senate confirmation process. And then workforce development. Professor Butterfield spoke earlier, excellent presentation about Washington State and our nursing workforce. But we as a country need to have a better understanding of our current workforce and what our future workforce needs are for physicians, nursing, nurse practitioners, physician assistants, other allied health professionals, pharmacists, physical therapists, audiologists, all of those people. And so this seemed to be a really good idea, that we would have a national workforce, that they would evaluate what we really needed to have in the way of health policy to support the development of the kind of workforce that we need. Obviously, I'm biased that what we need is a more, in the physician perspective, more a higher percentage of our workforce that's primary care physicians compared to subspecialty. We currently have around 30% of our workforce is primary care, 70% subspecialty. All the other first world countries that you hear about and the success that they have in better outcome measures for quality for their population, their primary care physician makeup is at least 50%. And there's all kinds of data from around the United States and around the world that the higher your per capita number of primary care physicians, the higher your quality metrics and the lower your costs. So this was a great idea, and this was another political casualty, because the other thing that's happened in the political process is that the Affordable Care Act authorized a number of different things, but for many of them, the appropriation of money was separate. And the appropriation of money to this commission was separate. It was a mere $3 million, and it didn't pass. So this work is not happening. About workforce, one of the other features is the idea of what's called a teaching health center. You take a federally qualified community health center and its service mission to take care of poor and underserved people in a community. And in Spokane, that would be Chaz and the Spokane Falls Clinic that do a fabulous job of serving those folks. But the idea would be then to embed in that environment a residency training program for primary care physicians, particularly family physicians. And so you'd have the dual mission of serving that population while training the primary care workforce you need, and some real synergy then, because these federally qualified community health centers are desperately attempting to hire more family physicians, and there just aren't enough of them. Our projection from the AFP, a 2006 workforce study, was that we would be short 39,000 family physicians by 2020, and obviously that's less than 8 years around the corner. So anyway, a couple more family docs. Freddie Chen, also at the University of Washington. He actually was contracted by Health and Human Services to write the teaching health center regulations. Another good state of Washington connection there. Another concept that was not funded was the idea of primary care extension centers. And the idea there is very much similar to what those of us in Eastern Washington know as the agricultural extension service. Person comes out from Washington State University often, very knowledgeable about current farming practices and things, and reaches out to farmers in the area with best practices and helps them be successful. A lot of primary care physicians, particularly in really large areas of rural Eastern Washington, are just struggling day after day to get by. And they want to adopt new models of care and electronic records and all those type of things, but they literally can't get away from their practice to do those things. And the extension service would bring services to them to provide that. And it was not funded, but it was that piece of legislation written. Kevin Grumbaugh is the chair of family medicine at UCSF. And the other reason I bring his picture in is another plug for primary care. People here read Michael Pollan's books about eating. He writes books. One's called The Omnivore's Dilemma, and the other is Food Rules, 64 rules about how you should decide what you eat. I'll share a couple. One is, if it comes from a plant, eat it. If it's made in a plant, don't eat it. Don't eat anything that has ingredients that a third grader can't pronounce. Don't eat anything that your great-grandmother wouldn't recognize as food. And so, anyway, great rules. I recommend his book. If you're trying to eat healthier, it's a good book. Anyway, his analogy to primary care, and actually back to Michael Pollan, he goes, his basic rules distill down to eat food, mostly plants. Eat food, not too much, mostly plants. And the extension to primary care is get health care, not too much, mostly primary care. So what wasn't in the Affordable Care Act? apologize, the geek speak here, but the SGR, the Sustainable Growth Rate Formula, is that thing that spits out negative updates to the Medicare physician payment schedule every year. You hear about, gee, if they don't pass something, your doctor might take Medicare patients anymore. This is scheduled at the end of this calendar year to cut physician payment under Medicare by 32%. It should have been included in the Affordable Care Act. This is one can that they kicked down the road. There was no meaningful medical liability reform. They included some pilots with a small amount of money, but it really wasn't meaningful, and that's a real significant issue to practicing physicians. When there's economic analysis of it, in those analyses, it doesn't appear globally to add that much to the healthcare total expenditures. A lot of us doctors find that hard to believe. And then again, I really am not convinced that there's adequate measures to control costs. But I do believe the future is what you make it. And for all the people who have been on the panel and anyone in the audience who's involved in making our healthcare system better, please keep working because we're all going to need healthcare someday. So thank you very much.
I don't have any slides, for better or worse. I do have slides, but I'm not going to inflict them on you. There are about 30 of them. But I thought what I'd do is just kind of recap some of the points that were raised here and maybe try and integrate them a little bit and then open it up for questions. Before I do that, though, I noticed Patricia made kind of a subtle plug for increased funding and attention to nursing education for workforce development. And I'd also just like to note that I'm part of a accredited, nationally ranked master's program in health policy and administration here on this campus, which is a terrific program. The audience is well represented with our students and board members and other friends and allies. And it's an exciting time for us right now. It's nerve-wracking for all of us, but there's really a high demand for graduate education in this area, and we'd be happy to talk with you more about the program. So, after getting the advertisement out of the way, when we're characterizing health systems, and this was brought up earlier, there's kind of three interrelated classes of problems in the U.S. healthcare system. There are problems related to access, quality, and cost. And they're not separate, but they kind of require different kinds of policy initiatives to address. We've talked a little bit about quality and cost. I'm really relieved that Glenn covered the basics of the ACA. I felt that I might have to cover some of that, but I think he did a good job of the overview of it. I think the big challenge that the Affordable Care Act tried to tackle was the tremendous disparities in access. I mean, currently there are about 50 million Americans under age 65 who have no health insurance at all. So, when Paul was talking about the public and private health systems, both of those baskets are very leaky, and a large and growing portion of Americans aren't in either. Consequently, we have to cross-subsidize them in the public and private programs, and the uninsured are much more likely to defer care, to not fill prescriptions, to not see primary care physicians. And when they do seek care, it's usually at a later stage. It requires more expensive intervention, and it's inefficient and frankly inhumane. So what the Affordable Care Act tried to do, and what really all the health reform proposals, the competing health reform proposals in the last 20 years or so have tried to do, is expand access to address the growing number of uninsured. And the Obama administration decided, after much back and forth within the party, to adopt this model of really expanding the public system, primarily through expanding Medicaid eligibility and reforming the private system, and as an incentive to private insurers, also expanding that market and trying to bring in this large uninsured population into the private insurance market. And that's why a lot of analysts say that the individual mandate that was the topic of so much discussion last week in the Supreme Court deliberations is really central to the whole access challenge that we face. I mean, there are other strategies we could use to address that access problem. We could create a single payer system, and in fact, we have a single payer system in this country. It's called Medicare Part A and Part B, and that's for everybody over age 65. We could expand that to other groups. We could do a mandate of all employers and require them all to provide coverage, and then create heavily subsidized private insurance for the working age population that has to buy into health insurance. But somehow we need to solve that access problem. And the access problem, I'd say, is primary in all of the current health reform discussions. And once we deal with that, we can start to tackle some of these cost and quality issues. Once everybody's in the system, we can start to rationalize payment mechanisms and start looking at quality. What else do I want to say here? I mean, so there's a couple of major components of the ACA, again, that we need to talk about. One is this expansion of Medicaid, which was one of the topics of discussion in the Supreme Court deliberations. The ACA proposes expanding Medicaid eligibility to all adults with incomes at or below 133% of the federal poverty level. Right now, there's a lot of people that aren't covered in that system that will be covered in the Medicaid expansion. At least in the short term, the federal government will be subsidizing Medicare or Medicaid at a higher rate, actually at a Medicare rate, to lure in particularly primary care physicians into caring for this new Medicaid population. And whether or not that's deemed part of reform, independent of the individual mandate, is going to have a huge effect on the state and on the number of uninsured in general. We're dealing with the quality and cost issues, I think, in federal reform, mainly by looking at Medicare. Medicare is the biggest program, the most expensive program, and the one that's under the most direct control of the federal government. So we're experimenting a lot with these things that we talked about in the last session and a little bit in this session, like accountable care organizations. This is essentially a set of Medicare reforms. We're coming up with more stringent review of Medicare payment policy, in theory. Whether or not it gets funded is another issue, but we're trying to deal with the quality issues and the cost issues primarily through Medicare. We're trying to improve access through Medicaid and through the individual mandate. I guess from the first two kind of political science analyses of this, I'll take the liberty of asking the first question here. Chris was looking at a period from 1970 until 2010, a pretty 40-year window, and characterizing kind of partisan policy initiatives during that period. I'd say that Paul was looking at a much more narrow window, the last maybe 10, 15 years at the most. I mean, maybe back to the Clinton impeachment hearings and stuff like that. So I guess I would just like to follow up with, I guess, Paul, and say, is there something fundamentally different that's happening now in this transformation to kind of unregulated parliamentary system that we're evolving into, and how does that change the politics of health reform and the ability to respond to, say, changes like a potential hit from the Supreme Court about the legality of the individual mandate? So maybe both of you could address that.
Yeah, I think that's a great question, and it was certainly my reaction when I was listening to Chris's presentation, which I think is spot on if one takes a long-term view, that it's really, really important to bring the tax expenditure story in and to kind of recognize the partisan dimensions of that and how those two options have been played off against each other. It makes a lot of sense to me. But I was thinking to myself, that I think that tells us a lot about the path that we particularly were on in the 1970s. You know, if you look at Richard Nixon, for example, and the Nixon and Ford administrations and what was going on with domestic policy in general, I mean, they are just way to the left of any policy positions that could be adopted in the Republican Party today. President Obama made this comment the other day, which, okay, he's running for office, I understand, but still, it actually struck me as right when he said that Ronald Reagan couldn't win a Republican primary today. There's actually a lot of evidence, political scientists who study roll call votes over time and try to situate members of Congress compared with other members of Congress on this kind of left-right continuum, and it's very striking when you look at that data that the polarization mostly grows from Republicans moving continually to the right. And I think you can see that in policy issues. And so, whereas Chris's analysis would suggest, okay, Republicans are going to be as willing to spend, they're just going to do it by expanding tax breaks for their favored constituencies. That is just not my reading of where they are on these issues now. If you look at the Ryan plan is very cagey about this, right? They have huge tax cuts. They're clearly going to proposing huge cuts in spending on public programs, Medicare and Medicaid especially. Medicaid immediately, Medicare looks like, let's be a little bit more gradual about that because that affects more of our core constituencies, like Chris was saying. But they also want really big tax cuts. And they say in the Ryan proposals, well, we're going to offset those tax cuts by reducing tax expenditures. They don't say what tax expenditures they're going to reduce. You'd have to really, really slash tax expenditures in order to make up the money that's in their tax cut proposals. And it seems almost certain to me, and this is consistent with their rhetoric elsewhere, you would have to go in an aggressive way over the existing tax subsidies that exist for employer-provided plans. So the idea that they're actually going to, that if Republicans were in charge, they would expand them, I just don't see that. It doesn't, to me, that doesn't, it's not what they're saying, and it's not what they're doing.
I'll talk about what might be the partisan path forward if, for example, you gave in your question that the Supreme Court strikes down, let's say, all of Obamacare. I believe that the Democrats, who made an effort both for practical and political reasons to form a reform that both expanded the public system. You mentioned the humongous expansion of Medicaid, which, by the way, I think is underreported by the media. You're talking about taking what were state eligibility requirements, eliminating those, and creating national eligibility requirements. The projections are that 50% of the people who are not covered, who would be covered under ACA, would come from the expansion of Medicaid, right. And it's 42% of the projected cost. And again, it's not getting reported on nearly as enough as the individual mandate and exchanges and things like that. Also, there's the closing of the donut hole, there's expansions of S-chip, and as Glenn mentioned, there's the kind of boogeyman for the exchanges that if you don't do this, the federal government will. So there's that, and then there's the realization that in ACA, the private system's humongous. In order to bring private insurers and the Republicans on board, you needed to do things that built on the private system, which the ACA, I would argue, is very friendly to the private system. I mean, there's a reason why health insurance companies and the AMA and all the other groups that railed against Clinton Care not only either didn't say a word about Obamacare or were supportive of it. That's because, as Paul mentioned, they were brought in the process, and the exchange was, we're going to regulate you more in exchange for you getting more customers. So given that this was an attempt to stake positions that Republicans had supported just 5 years ago, and the Supreme Court might strike it down, and there is no Republican vote for this, I think that if this is struck down, the Democrats will not immediately, but in the future, say enough. Like that we will expand healthcare access through incremental changes to Medicare and Medicaid. Period. And no more playing nice with the Republicans, that we tried that, and the Supreme Court and the Republicans didn't work with us, so we're going to do this our way. Now, as Paul mentioned, the Ryan plan is drastically different. And I agree with Paul that the Ryan plan doesn't work through tax subsidies so much, but where they would fit into my theoretical argument is that they surely use the private system. I mean, the Ryan plan is a part of a 40-year effort that started at think tanks in the 1970s to privatize Social Security and Medicare. And what the Ryan plan does, there's been debate about whether it gets rid of Medicare as we know it. It would give people grants. Instead of Medicare, you would get grants, and those grants would go right to the private insurance companies. And those would be subsidies for the elderly to buy Medicare. So the government as a provider for fees for service is gone under the Ryan plan, and what happens is that the federal government gives subsidies right to the private insurance companies. CBO has done analysis of the Ryan plan, and the numbers they came up with were that if the Ryan plan was passed, I'll just give you an example instead of going through all of them. Right now, the elderly spend 20% of their Social Security checks over a year on healthcare services. If the Ryan plan was passed, that would go to 50%. 50% of what people take home in Social Security, the elderly, would go towards paying for healthcare services under the Ryan plan. And then Medicaid would be changed into a block grant system given to the states. So make no bones about it that the Ryan plan is a plan to privatize, which have been, again, I can give you a list of policies over the past 40 years offered by the Republican Party to do these. And there are political and practical reasons for why they want to do so. So, as Paul mentioned in his speech, there really is a humongous amount of difference between the parties, and the ramifications for who gets covered, who pays, if Obamacare is struck down, it's hard to see some type of middle ground.
Do you want to weigh in on this, Glenn? You take a pass on it? I don't blame you.
No, I'm just waiting for the Supreme Court, then we'll know which.
Yeah, I guess my reaction is that something has changed in my lifetime of doing health policy stuff. And I think I'd like to think when I started doing health advocacy, health policy advocacy, there was agreement at least that, for example, the growing number of uninsured was a problem that needed to be addressed somehow as a society. It's something one of my advisors in Berkeley referred to as the moral economy, which is kind of these fundamental values about what we owe each other and whether fundamental goods like health services should be distributed through the market or through kind of a series of separate relationships out of the market, transactions that are based on cross-generational expectations of support and minimizing really the kinds of social disparities that we're otherwise dealing with in terms of, age, certainly class, gender, race and ethnicity, disability status. And it seems like that's kind of gone now. I mean, we're not even agreeing on the fundamental problems that must be solved. And that's new and kind of disheartening, I have to say. I don't want to end on a down note.
Yeah,
I guess I'm confirming your observations, Paul.
I think we need to be clear what we mean in this case when they say privatize. Or they don't say, if we're talking about privatizing, we're not saying, as we were with the kind of private welfare state that was built with tax subsidies in the middle part of the 20th century, we're not saying private sector is going to provide these benefits for you and we're going to subsidize them with tax benefits. We're saying the federal government and increasingly state governments are no longer going to pay for your health care as it becomes more unaffordable. And if you can pay for it some other way, that's great. And if you can't, you're out of luck.
Yeah.
Right? That's what it means. Because they're not talking about, as the stuff for the 70s that you're talking about with Republicans in the 70s and 80s, they're not talking about ramping up tax expenditures to support private health care. They actually want to scale those back at the same time the costs are going up and at the same time that they want to scale back public spending. So the end result of that road is people not getting health care.
Right. And that's a road that we're already well down. Okay, let's open it up to some other questions.
I'm actually here to speak in defense of broccoli. It's not that broccoli's bad, it's that Americans don't know how to cook it. But my serious question, I'm Paul Whitney, I'm an Associate Dean for Research in the College of Liberal Arts. This symposium actually started in a conversation that John Pierson and I had, I guess close to a year ago. And one of the things I was impressed with when I met with John was that he represented the insurance industry, but right away when he came into the room, he didn't have horns. There wasn't horrible odors emanating from his body. He seemed like a reasonable guy. But the whole tenor of this has been that this is such a difficult and contentious issue, and I'm certainly not here to deny that. But one of the things I noticed today as we went through this, and really in almost every speaker, there was a point of agreement. And so when we have an issue like this, sometimes starting with where a lot of people agree is maybe a way forward other than just leaving depressed, which is also an option, is that almost everybody spoke to, and this certainly won't solve all of our problems, but prevention and a focus on wellness rather than just a focus on illness seem to be a large point of agreement. And yet, over, again, the last 40 years, partly due, I think, to us convincing ourselves that we had defeated infectious diseases, wrongly, we kind of have dismantled somewhat our public health system. But there are, even though there's so much agreement, and John spoke to the healthier their customers are, the better off the company is, and they really want to do innovative things to help their customers be healthy. And public health people been trying to do that for decades. Now, there are some obstacles to that orientation. You do hear things like, my opening joke, the broccoli and the nanny state. So I guess my question for you guys beyond that observation is, there do seem to be at times a lack of political will and sometimes policy and politics getting in the way of a good public health system or a wellness orientation in our overall health economy. Are there some ways to take that point of agreement between among physicians, nursing, insurance, and get past those political obstacles? Or is there a way to move forward on a health orientation that gets us out of charges of the nanny state and political blockages to that kind of orientation, which at least would be a step forward?
Sounds like a good question to make a bid for integrated primary care. So if you want to take that one, Rob.
Yeah, I'd like to think that we're making incremental progress in educating our populace. Mary Shalecki made the comment about how much of people's health is their behaviors, and it maybe is even more than 50%. It's humbling for physicians, but when you look at what are broadly called the social determinants of health, the health care that people get probably has about a 20% contribution to their overall health. The rest of it is genetics, environment, and health decisions that they make to smoke or drink or exercise or not. Your comment was well taken about public health, and there historically has been a better alignment between our primary health care delivery system and our public health system, and both are badly broken and badly overfunded, partly due to our country's fascination with technology. We think that the best medical care involves the latest scan, the coolest stent that's drug coated, and all these things. And we have turned a blind eye to the evidence that shows that actually has very little impact on your quality of life, your longevity, and the health that you enjoy. And in fact, the two most determinants of health is if you have a usual source of health care and your zip code. And your zip code determines, do you have access to a place to exercise? What are the environmental toxins in your environment? Can you find healthy food to eat? I mean, we have huge parts of our country that are called food deserts. And if you live in an inner city area in many cities, unfortunately Spokane is not one of them, what there is fast food restaurants and convenience stores. And you would want very hard to find a fresh apple or something to eat. And, we need to align the health policy of our country in the broadest possible sense directed at health.
Well, I think we might be at our stopping point, and that was a more positive note to end on. So we'll go with that.
And we can get there.
Eat your veggies, and thank you for attending.
Thank you very much. Let me remind you to join us for cheese and wine receptions in the atrium. It's just around the corner here. And now, on behalf of the Foley Institute and the College of Liberal Arts, I want to thank you all for coming out today, and join me now in thanking our panel for a really interesting discussion.